Good afternoon, everyone. Thank you for joining our IHER Health Equity Seminar Series. My name is Utsa Khatri, and I'm one of the core faculty within IHER. This is an ongoing lecture series that features experts from across the country who share their research and insights on key topics related to health equity. We have a very special speaker for you today, and it is my absolute delight to have the joy of introducing him. Dr. Atheendar Venkataramani is an associate professor in the Department of Medical Ethics and Health Policy and a staff physician at the Penn Presbyterian Medical Center. He is a health economist who studies how social and economic factors and policies affect health and well-being throughout the life course. His research, which combines insights from economics, public health, and clinical medicine, spans both domestic and international settings. Dr. Venkataramani directs the Penn Opportunity for Health Lab, a research group that seeks to identify policies and interventions that can jointly bolster both economic opportunity and health in the United States. He completed his medical degree at the Washington University, his PhD in health policy at Yale University, and his bachelor's in biology and economics at Duke University. He completed residency in internal medicine and global primary care at the Massachusetts General Hospital. Athene was actually one of my associate program directors during my research fellowship, and people often joked that he was one of the rare economists who had a big heart. I remember he developed a health equity curriculum for our fellowship that I continue to reference, and he has a remarkable ability to make very complex ideas and methods accessible to all learners. Without further ado, Athene, take it away. Thank you so much for joining us.
Hey, thank you so much. And that was such a wonderful and kind introduction. And we all miss you at Penn. And just really excited to see what you're doing over at Mount Sinai. All right, I'm going to share my slides, and I'll just confirm that you can see that.
We can see
Um,
them.
Perfect. All right. So I know that I provided a different title for this talk, and some of those concepts about status threat will enter here, but I wanted to talk about something more general, especially given the events last week. Um, just some disclosures. The only thing I think for a medical audience that's relevant is that I own some stock that has nothing to do with what I'm about to talk about. Um, so just to fix ideas, I think you all are here in part, and you're doing the work that you do because you recognize that population health in the United States is not what it should be. And here's kind of a empirical kind of manifestation of that feeling. What we have in the blue circles is the number of deaths occurring across all ages in the United States from 1933 to just after the pandemic started. And then we have these unfilled circles, which are basically the death rates, what the death rates in the United States would be, or mortality would be, had we followed the age-specific death rates of our peer countries, which are similarly wealthy. And what you see is that until about 1980, we do pretty well relative to this counterfactual, which is mainly Western Europe and also Japan. And some years we're even below this counterfactual. But starting in the 80s, things got worse in the United States relative to itself, as well as peer countries. And we had this huge gap between these two lines, suggesting that many Americans have gone missing. If we kind of take these numbers at face value, today, 1 in every 2 deaths of someone under the age of 65 in the United States would need not have happened had we followed the trends that we used to have and that other countries continue to see. This health crisis has been 40 years long, and you can also see it in different segments of the population. Everybody is affected, but some more than others. In this graph, we've basically taken counties in the United States, and for each census year, we've ranked them into percentiles of college education. And so counties with the lowest levels of average education, you start to see this increase in mortality starting in 2000, right? That's unprecedented. For counties at the median, you see this increase starting in 2010. And even for those in the 90th percentile, you see a flattening and perhaps a hint of an increase starting in 2010. And this is after these counties kind of followed similar trends over a 10-year period, though we can't really make this graph further out to be sure. right? So people's lives and their life expectancies are now increasingly linked to education in ways that were true before, but not to the degree. You all know that Black and American Indian persons are overrepresented among the missing Americans. And if you look across states, we have varying degrees of performance in life expectancy, though the best performing states are still, I think, perform worse than the average Western European country or Japan. So, what's going on here? I think every few years we've seen articles like this, right? Especially since 2014 when life expectancy here began to drop. Um, and there's a number of reasons that I think you'd all come up with. The first set of these reasons have to do with our healthcare system, who has access to it, how the level of quality that's in the system, and then people's behaviors, right? I think we're still very individual centric in the way we think about health. And so, things like smoking, obesity, alcohol use, we tend to identify as risk factors for premature mortality. So that's one tranche of explanations. The other has to do with the environment. So pollution, climate change, the availability of firearms, synthetic drugs, the quality of roads. These are all things that increase people's mortality risk in various ways. And then there's a whole other set of explanations, which is what my lab has worked on, which have to do with economic insecurity that people face, the opportunities they have in the labor market, and what that means for their material resources and well-being, and then the social safety net, whether that does a good job catching people or not. There's also structural issues that relate to the economy, the degree of built-in discrimination historically over time, all of which also shape health. So I think if we were to come up with a list, we might have something like this. There might be a couple of things that I missed here, but for the most part, this is what we generally talk about when we talk about American life expectancy. Um, I'm going to tell you that all of that is correct, and really, this talk is about why we haven't fixed it. Um, and the idea behind this talk, my answer to that question is, I don't think we've delved enough into the sentiment of those affected by the mortality crisis. And what I mean to say is that I think in being a physician, I've kind of come across this common sentiment that I think might unify the experiences of different population groups and to try to get us to understand what's going on with people's health and why haven't we made huge inroads into fixing these really deep problems. And if you agree with the sentiment and my reading of it, then I think the sentiment actually maps onto a set of economic and social science theories that imply a common framework on how we should go about addressing our life expectancy crisis, as well as the type of language that we might bring to unify actors that typically are in conflict when it comes to taking on some of the policies that we might need to fix these issues. So, what's the sentiment? So this was from residency, actually. So this now going back 10 years almost. And I had a patient who was, I think one of those disaffected white men that we keep hearing about now, especially in this election. But this was a gentleman in Massachusetts who I was seeing quite frequently. He wanted to quit smoking. That's what he had mentioned to me when I was an intern. And by the time I was a senior, we hadn't made headway. And I asked him about that. And his answer to me was really telling. It was what you see here, which is, I don't see the point of doing this. Like, I'm not getting out of here. I feel stuck. And I asked him what that meant, and he basically said this, like, look, I'm this guy, like my parents were working in shipping. This was in Charlestown, Massachusetts. My parents were working with shipping. They seemed to have good lives. Like I had a nice childhood. I thought I was going to do kind of the same thing, but those jobs are not there for me. I don't have a college degree. Um, like I don't have the money to kind of live in Charlestown anymore because it's gotten really expensive, but I also don't have the money to move away. So I'm not really sure what I'm doing next and what the future looks like. And so I kind of feel trapped. So that's the sentiment, this idea of feeling stuck. This idea that people feel unable to change their circumstances despite their best effort, right? And in many ways, this is the perverse mirror image of the American dream, which says that if you put in your best efforts, you can change your circumstances. And this sentiment has a material reality component that comes with it. And that is this idea of cascading cyclical disadvantage across multiple domains of people's lives. And this can be at the level of people who go through these cycles or communities that can go through these cycles. And I showed you that news article that called America a rich death trap. We spend a lot of time talking about rich and death, we don't actually spend a lot of time talking about trap, but I think trap is the operative word. And that takes me back anyway to earlier in my training as a PhD student when I was studying development economics and this idea of poverty traps that exist where people are mired in these negative cycles. We're seeing some version of that, I think, in the United States increasingly. So that's the sentiment, that's the reality, and that's the theory that kind of brings it together. So I'm going to tell you about another case about how people can get stuck and sort of show you what I think the cycle looks like in America. Um, a lot of this comes from actually seeing patients, and then some of it comes from what I've read as an economist. So I'm going to tell you about Linda, who was a 52-year-old home health worker. Um, she was in what I think would be considered one of the good jobs now, in terms of healthcare being the highest uh, fastest growing sector for low wage work. And she had one of these steady jobs, patient facing, taking care of people who were at the end of life or who had some kind of disability. But the job was hard, right? So she was a contract worker. She would change, or she was shuffled about different places. She shuffled through different contract firms. She was in and out of insurance. Her job was hourly, so like she had to show up to get her hourly wage, which was, probably 15 to $18 an hour in Massachusetts, but she had to work really hard to kind of get that. Around the same time she was doing this job, and when I met her, her husband had a workplace injury and had to go on Social Security disability insurance, and she had to take care of him. So that the SSDI did not cover the income that he had lost from his work. She had to work every hour to kind of make ends meet, but she also had to spend the rest of her time engaged in caregiving. So that was really tough for her. And when I met her, I had actually diagnosed her with hepatocellular carcinoma, likely from Hep C, from a roadside tattoo. Um, and we were stuck in this kind of cycle where she was in and out of insurance. She didn't have a lot of time. When I did see her, it would have to be at like 9 p.m. in the hospital cafeteria so we could avoid facility fees and all of that. And we were trying really hard to get her to oncology. The problem with the oncology appointments is if you go, you have to go for 6 hours to meet all the specialists and everyone. We tried to find ways to break it up, and everyone was thinking creatively with it, but we just kind of ran into these hurdles. Um, During this time this happened, her mother got sick and she had to take care of her. So now she had additional caregiving responsibilities. She couldn't give up that extra hour of work. And so it became harder and harder to get her into regular visits. And you could see it happen to her over time that she's this like really vibrant, lovely person, really super funny. But all of that kind of disappeared. I saw her become hopeless. I saw her feel like there wasn't much she could do to change her life, and that she was always expecting the worst instead of looking forward to the best. And this weighed on her. And then at some point, I lost her to follow up. And we tried to reach out, we couldn't find her. And a year and a half later, I found out that she had actually died. I'm not quite sure from what. I have a suspicion that it had to do with the tumor, but that's just speculation. But whatever it is, she was mired in the cycle and couldn't get out, and that shortened her lifespan. There are lots of people like Linda that I've met, and they enter these cycles through multiple ways. It could be a job loss, it could be a family member getting sick, it could be a shock to their own health, it could be because of um, because they, by some chance, happen to fall into cycles of addiction. It could be because of incident depression. But whatever it is, they enter this and they are unable to get out, and the cycle reinforces itself. And the risk of falling in, like these traps that are set and get people stuck, have a lot to do with the economic, social, and political forces that affect people. And that's kind of what I want to let's say a little bit more about in just a bit. In terms of stuckness, like how common is this? I'm talking to you about patients that I've seen. And okay, so this is from Google Ngram. So you can search the English language lexicon for the mentions of words like stuck and trapped and stuck in life in books. And what you kind of see is that starting around 1980, it showed up in our English language books in a profound way, and it's culminated in this decade in particular, right? So this is a common sentiment. But what was happening in 1980, I already showed you the graph of how we fell off the curve in terms of our death rates at that point relative to our European peers. But it's also a common breakpoint for a lot of other social factors. So when social mobility started to fall, that is the likelihood that an individual born to a bottom quartile income family would make it out of that quartile, started to fall around 1980. Income inequality started to widen around 1980. The fall in migration within the United States to opportunity fell around the 1980s. Marriage rates declined around the 1980s. And we already talked about mortality, right? So this stuckness frame, this sentiment is occurring and kind of coincident temporally to all of these things that we see in the data. And you can go and ask others, around the country, like about this sentiment. And so we did a survey actually where we looked at, we asked open-ended questions to about 150 Americans all across the country. It's a small survey. We're about to deploy a larger one. But this stuckness frame really struck a chord with people. People were talking about themselves, how they got stuck when they had periods of unemployment and poor health. They talk about a friends who got mental illness and was stuck in the spiral of unemployment. They talk about a mother is talking about her son. Um, and one of her other words was she's unable to get off the couch because he's physically and mentally doesn't feel great and he's stuck as a result of it. People getting stuck because of addiction and then people watching their parents get stuck. So like this came out in multiple different um, settings. This phenomenon of stuckness is experienced in either personally or through a family member, at least in our survey of people across the wide socioeconomic spectrum, racial and ethnic demographics, age demographics. So this is something pretty universal. It's also something that I would say that's trackable in the data, but not in the way that we've looked at the data. So I talked about some of the trends and these social factors that have changed over time, but you can actually look at individuals, like we collect lots of surveys, and you can get a sense of what stuckness looks like just by looking at them. So one of the things that I did actually for this talk was I looked at the National Health Interview Survey, which is fielded every year. It's large. We get a lot of information from that. And they ask lots of questions, right? And so what this is plotting is what people who don't have a college degree versus those who do have a college degree. That's one of the widest kind of cleavages in terms of divergent population health trends that we've seen. And among these people, among people who are surveyed, they answer a lot of questions. So this looks at the share of people with at least 4 out of the 5 of the following, which is they report feeling hopeless, they report not being married, they report not having moved geographically or being stuck in place, they report some kind of disability that limits their daily lives. And they report being out of the labor force. And these are all individuals between the ages of I believe it's 20 and 59. And what you see is that this is from 97 onwards, but if you follow this from 97, folks without a college degree, there's an increasing proportion, about a 40% increase in the number of people that have multiples of these disadvantage, 4 out of the 5, right? And you can construct this any different way you want, but there's concentrated disadvantage among individuals, which is exactly what you see if people are getting stuck in cycles. It'll hit very different domains of their lives. For those with a 4-year college degree or more, you do actually see a little bit of an increase. It's not like they're spared from this phenomenon, and there's a doubling, but from a low base. But this gap between 4-year degree and non-4-year degree has widened, suggesting that there is something kind of pervasive about this concept of stuckness and people getting trapped that has increased over time. What do we do about the stuckness problem? So you all, and then folks around the country, people in disciplines like social epidemiology, economics, sociology, demography, you name it, have actually come up with a lot of good studies that link various social programs and social phenomena to health outcomes. And in this slide, I'm just trying to organize where they would go in terms of getting people out of this trap or breaking these traps altogether, right? You got to set them and get people stuck. So some of these policies, like programs that increase access to education, programs that provide fair wages, the tax credits like the EITC, civil rights, these things boost opportunity and security for people such that they're not at risk of getting trapped to begin with. And then there's other policies that try to break the links between this. So if you fall on hard times because you lose your job, unemployment insurance, SNAP, other cash assistance programs, all of these types of things are there to try and prevent you from sliding into kind of losing some of these material and time resources and losing hope, agency, and all this other stuff. There are policies, if you think about this from this framework, that you wouldn't necessarily think about as relevant for population health, such as voting rights, but they very much are. Part of it because it shapes kind of the overall picture that we're seeing, but also part of it because it gives individual agency to human beings so that they come in with some capital when mired in the rest of the cycle. So there are various ways you could organize the thinking around policies that affect health. I thought this is one useful framework about getting into negative boxes and then transitioning to have multiple negative boxes happen to you. I think that's what policy can help prevent. And so if you buy the stuckness frame, that's really what it's about, right? Like you don't want to set the traps in the first place, and then you want to pull them out when they do. And so it's the types of policies that I suggested, the things that affect the boxes, preventing people from getting into those negative boxes, and then and the types of things that prevent people from transitioning from box to box. There are two things that come out of that I think are less obvious. The one is that we tend to think about policies in economics as let's look at a study that tries to understand what is the effect of the child tax credit on health. That's great, right? We rarely ask the question, how does the child tax credit work when other policies are present or absent? So if we've set a multi-dimensional trap, what is probably true is that you need multiple policies that work together to kind of keep people out of it and allow them to flourish. Except in our science, we don't really think about complementary interventions that way. So I'll talk a little bit about that in a second. The other piece of it that I think is really important is that the psychological effects of the interventions might be as important as the material ones. So in my clinical work and then also in some of the research I'm doing, increasingly seeing that expectations, hope, and agency are a large driver for some of the mental health and stress-related physical health consequences that we see. But when we talk about policies, we don't really talk about that. So I'm going to trace out each of these in a little bit more detail. Just before I go on, are there any questions? I don't know, Usha, if I should take questions as we go or what you would suggest.
I think we can save them for the end.
Okay, great. Perfect. All right, so let's talk about the first piece, which is building resources so that people don't so people are bolstered, they don't fall into these negative boxes, and then also allowing creating a world where we don't transition from one of those boxes to having other domains of life affected, right? So this is from a paper we did a few years ago. It's called Death by Robots. And the point of the paper was to look at what happened when parts of the country, like the industrial Midwest, here in the red and the South, automated industries that previously were, the pathway to middle class jobs in the United States. So a lot of this is manufacturing, in particular, a little bit of oil and other stuff as well. So some places automated more than others. And what we showed was that where there was increased automation, especially among middle-aged adults, you saw this increase in overall mortality. A lot of it had to do with drug and suicide mortality, but if we look in the older group, the 55 to 64 in particular, cardiovascular disease was one of the biggest drivers, right? So as there was automation in the United States, there was this, people were pushed out of jobs, wages dropped, and we saw that show up in health. Our estimates, it's one force. Our estimates suggest that maybe automation explained about 55% of the increase in suicides among men of this age and about 13% of the increase in drug overdoses. Obviously, you take those numbers with a grain of salt, but it was important. That didn't have to be the case. So there's two ways to look at it. One is that when people when jobs disappear for various reasons because of technological change or other things, other jobs can take its place. And at least until 1980 or so, we were pretty good at that, replacing jobs that were lost with new jobs that were gained. So this is a situation where we look at the inverse, right? Like when jobs became available, especially for the types of folks that generally go into manufacturing jobs. So this is fracking. There's lots of issues with fracking, many of which are negative. But one positive thing was that it employed a lot of people that, like my patient from the beginning, Eric, that would not have had the opportunity to work in industry like their parents did. And what they found was in this paper by Murthy and Chocola was that there was this decline in mortality. So the opposite of what we're seeing when these opportunities become available. Another piece that I think is really interesting is, there was another paper we wrote about auto plant closures and what that did for opioid mortality. And um, the folks that called me about that paper, because they were interested in the policy implications, were actually from Canada. They were from Ontario, where, like in Michigan, across the border, they had automotive plant closures. But in Ontario, there wasn't this kind of social decay and increase in mortality. As a result of that. And one of the reasons was they were very good at taking people who lost their jobs and reskilling them quickly for other jobs that were available in the industry. So you might want to think in the United States, like when that happens, we make a big news story about it, out of it. So you can think of like the Shinola Watch Company, right? Like that employs like ex-auto workers. Canada does that as a policy, or Ontario does that as a policy. And in the United States, we actually have like job reskilling programs that work. So in this graph, you can see that as people go through these job reskilling programs, their monthly wages are actually $500 higher than they were prior to entering this program. So we actually have the capacity, if we scale up, to potentially take people who are out of the workforce and whose health is suffering as a result, and just, in a way that I think, really preserves kind of the spirit of why people want to work and the benefits of working, get them into industries where they're able to thrive again. Even in our case in the United States with the auto plants, it didn't have to be that way that people died. So what we looked at was we wanted to see, well, if you lived in a place that automated, but you also happen to live in a place that had more generous social programs, were you more likely, or did you actually have lower risk of dying as a result? So where there was better welfare policies in general, you can see that suicide mortality was lower. Where Medicaid was more generous, you can see that drug overdose mortality was lower. And where unions were able to provide a counterweight in terms of bargaining on the behalf of workers, you can actually see that all-cause mortality rates were lower too. So even within our own borders, like we had this immense heterogeneity in whether people died as a result of losing their jobs or not. So we can learn from each other. The second thing I told you was that policies have to work together. We often think of them, though, as separate. We haven't done a lot of research on complementarities between policy, especially um, in kind of the clinical and public health communities. It's too bad because when we treat heart failure, we treat people with like 4 or 5 agents, right? All of which we think physiologically work together in ways such that the sum might be greater than the parts. That's got to be the same with the social world, which is, I think more complex in some ways than cardiac physiology. But whatever it is, we're not doing that. But when we do look into these complementarities, we see that they're immense. So in this graph, I want you to just pay attention to the gray bars. These are all kids that had access to Head Start growing up when the program was rolled out. And so what happened was some of these cohorts, so on average, Head Start was good for about a 0.3-year increase in education. In the economics literature, that's pretty big. But these cohorts that went through the rollout of Head Start also faced some very different funding streams as a result of court-ordered desegregation in terms of K through 12 spending. And so some people didn't see a lot of increase in K through 12 spending, and there the impact of Head Start was actually close to zero. But where there was this complementary increase in funding after the Head Start years in schooling, you actually saw overall years of education and adulthood increase by 0.6 years, which is huge, right? So what this is basically saying is that these two policies have built on each other to create multiplicative gains in terms of their impacts on what education, and probably they had health impacts too as a result of it. And I'm sure that many of the policies, some things might substitute for each other, but if you think of the way people get trapped, these different boxes, policies that bolster people, for example, paid sick leave, paid family leave, long-term care insurance, can interact positively with policies in the labor market, right, like minimum wages or earned income tax credit in ways that might generate multiplicative benefits for people that we don't necessarily see. You can also see this when it comes to the degree of implementing a particular policy. So this is, I alluded to this earlier, but what this is capturing is different counties in the US by the percentage of college graduates in that area on the x-axis, and then mortality. And then these are different years, right? So in 1990, there was a relationship between education and mortality. More education meant less mortality. But by the time you get to 2010, this line has become much, much steeper. Education matters more and more. And the reason for this is that when you have a critical mass of people with higher degrees of education, the policy environment changes for everybody. So if you're a person without a college education living in a high college educated area, you're going to benefit from all of the externalities of the different regulations, the different behavioral norms, the different policies that exist when there's greater degrees of education, right? So this is an example of complementarities by size of policy. So a small educational investment um, will take you so far, but if you invest deeply in education, um, increasing the access to college, vocational school, whatever, in a way that affects the larger population, you might actually see more bang for your buck. And the third point I mentioned that was potentially not obvious has to do with psychology. And so here, what I mean by that is policies can affect health even without changing people's material circumstances. They change people's level of stress, their sense of belonging, and their future expectations. And that bucket of hopefulness, expectations, the beliefs, that's one of the entry points or potentially, hopefully, exit points of getting stuck in a negative cycle. Um, so here's an example from from a paper that we're finishing up, or it's in the submission process, but it's up as an NBR working paper. And what we looked at was this policy in the 90s that some of you might know called three strikes policies. And these policies, what they did was if you were in a felony conviction and you've had two and then you had your third one, they threw the book at you and gave you a maximal sentence. The policy itself didn't do a whole lot for incarceration rates. There might have been a mild deterrence effect, um, but it didn't change crime rates in a big way either. But we do see for lower income Black women that their babies were more likely to be lower birth weight. And the magnitude of this effect is similar to the positive effect of the WIC program or something on birth weight, right? And it happened the year the policy went into effect. And the reason for this is not because there was any material change in the environment, but because the dialogue around three strikes was very stigmatizing. It talked about Black people as being potentially super predators, and it created this set of negative expectations about the future, reduce the sense of belonging, stigmatize people, raise stress in ways that you can see immediately in the data in infant health, which exquisitely moves to stress. This is sort of an ex post kind of thinking about what this policy did, but policy psychology can be built into the way we think about policies going forward. We're hearing an unfortunate type of, I think, deliberate policy psychology being discussed with regards to immigration reform that might be coming in the next few months. But here's an example where we might want to bake it in or think about it before we dive into investing in a particular set of policies. So one of the big conversations that we're having as a country, and there's now over 100 pilot studies studying this, is the idea that guaranteed income could be potentially transformative in terms of giving people a minimum standard of living and potentially for their health. There's a whole show, I think, on Fox called Universal Basic Guys, and it's about like people who lost these two guys who lost their jobs because of automation. The government gives them $3,000 a month, which is like actually a really huge transfer that is not being tested in the studies that have been done so far. But it's about how they spend their money. The show is fine. It's take it or leave it. It's you don't need to see it. But that's one set of policies, right? It's like we think our jobs are going to be automated. We want people to have a standard of living. Let's have a basic income grant, and that goes back to even the civil rights era where Martin Luther King proposed something like this. Martin Luther King also proposed a second thing in his Bill of Rights for the common man, which was job guarantees, making sure that everyone gets to work. And so there's a study going on now in Austria where they have a job guarantee program, and some economists are studying it and showing that it has some really positive effects on well-being, and it's too early to say if there's health effects or not. So these are two pathways that we can take, and they might be complementary to each other. But the interesting thing is, I might guess that the jobs-based policy, especially if they're good jobs, will have bigger health impacts than the income-based policy. And the reason I say that has to do with this just the nature of work in the US. So this is a study from Bangladesh actually on refugees. And they took refugees and randomized them to three different arms. One was a control group, the other was a group where people were given cash every month, and the third was a group where people were given a job. And both cash and work did better than than the control group in terms of overall health, right? And these various measures like PHQ-9, healthy days, whatever it is. But when you looked at work versus cash, work did better than cash on almost all of these domains, to the point where two-thirds of the cash group asked to be in the work group and would be willing to forego 6 months' salary to do so. And it just points to the fact that work, the dignity that comes from it, the sense of purpose, these are important things. They may not be in the future, but at least in modern American society, they are. And having that psychology piece in mind is going to be important because if, let's say, we're asked to choose between basic income um, and job guarantees for a budgetary reason, and we're trying to maximize the health impacts as well as other impacts on well-being, we might actually pick the job guarantee over cash if we were to take if the psychology piece matters a lot. So if you believe this narrative of stuckness and being trapped, right, what do we do going forward, and what do we do in healthcare? So I'm going to conclude by talking about that here. Um, The first thing we need to do is, I think we have to do better with developing and testing multi-level, multi-component interventions. Try to figure out what are the complementarities between interventions at different levels and different types of interventions. Um, some of you, I think actually all of you probably know Eugenia South, who's a professor of emergency medicine here at Penn, and she and I are running this study called the IGNITE study. And the goal of the study is to basically bring in complementary interventions. So one of the ways to read what's going on in Philadelphia in terms of health, especially among Black communities, is that entrenched structural racism raises economic risks and reduces economic opportunities and negatively affects the built and physical environment, which leads to a number of different challenges that affect health. And if you buy fundamental cause theory from sociology, intervening on any one of these arrows is not going to be enough because the other arrows can kind of rise up and take its place to produce the same health outcomes. So our goal is in this study to try and hit both of these bigger boxes through providing financial counseling, a one-time cash transfer, easier access to benefit programs, free tax preparation, and then on the built environment side, vacant lot greening, abandoned house remediation, planting trees. And we're actually in the field now collecting N-line data. And in about 8 months, I think I'll be able to tell you if this worked or not. Our qualitative data so far suggests that people appreciate the interventions and they think um, that it has transformed their well-being in certain ways. Whether it affected their health or not, we'll see. This other thing that we need to do in addition to these multi-component interventions is try and understand policies work for some people, but not for others. And some policies work in certain environments and not in others. And trying to really get a sense of what that looks like, in what situations do certain policies work and when do they not, is going to be really important as we try to understand how the pieces fit together in terms of complementarities. Another thing that we should do going forward is we should not let people get stuck by design. And unfortunately, our safety net does this, gets people stuck, I think, in ways that are sort of unfortunate. So this is actually government benefits received by adults without disabilities in various income bins, right? So this is like the top income bin, 6th to 10th. This is the first decile, and this is the middle. And what's fascinating about this graph is that since 1990, in the first decile, we had this decrease in benefits. And I think, as of today, it's probably a little lower than it used to be. But if you look at the middle deciles, there has been a nice increase in benefits, right? And the reason for that is the folks in the middle decile are working, and we have increasingly tied the safety net to work. And because we do that, there's the possibility that people who, for whatever reason, like my patient's husband, Linda's husband, were unable to work, they do not have a net to catch them that was as robust as it used to be. Even in policies that work well, there's the potential to get people stuck. So this is by Paula Chatterjee and co-authors in a paper from 2 weeks ago in Annals of Internal Medicine. And what they do is that they look at the fraction of people in various income bins relative to the federal poverty line, so ranging from at the federal poverty line all the way to 400%. And then they look at the share of people within those bins. Um, the the shaded bars are Black and Hispanic beneficiaries, and the non-shaded bars are white beneficiaries. They look at the share of people in these bins who, by virtue of having to pay the Medicare Part B deductible, might potentially fall into financial precarity. So they would lose all their assets and potentially be in this cycle of poverty. And on average, across all of these folks, it's 50% of people between 100 and 400% of the federal poverty line who are insured by a government insurance program may actually fall into financial precarity because of a health shock, which is the opposite of what insurance should do. But here's a place where, by design, people could get stuck. We also do funny things to get people stuck, to get places stuck by design, and some of them are not obvious. One of the things that I didn't know until I started working with Manuel Schechtel, Rourke O'Brien, and Robert Manduca, who are sociologists who study fiscal America, is how states share revenues that come from taxes. So some states, like those, like actually here in New York, right? So New York is a state where there's a lot of tax revenue, so this is probably why. Um, from a levels perspective, New York does well, or one of the reasons. But if New York City, let's say like I'm from Albany, right? So I'm from Saratoga County. So let's say Saratoga County, is where I grew up. Um, they lose like a bunch of manufacturing plants or other things. This actually happened in Schenectady County, which is next to me. So in Schenectady, auto plant disappeared. Schenectady is still having a rough time. I think they're slowly getting out of it, trying to invest in ed and med like everyone else. But in New York State, taxes that are taken to the state government are not dispersed kind of in an egalitarian way. So Schenectady is kind of on its own. But in West Virginia, which is poor, but in West Virginia, if a place goes through a hard time, and unfortunately many places did, there's more revenue sharing across the state. So things that are collected by the state government get more evenly dispersed. And that makes a difference for equity. So the more centralized you are, the lower is the variation across census tracts in mortality, right? Some of these states are poor, some of these states are rich, so this doesn't hold in terms of levels, but these kind of stylized facts about one census tract having 20-year, 25-year life expectancy greater than another census tract are less likely to materialize in states that, for historical reasons, happen to share money versus those that don't. But this not sharing money is a recipe for places to get stuck in sort of profound ways. And then there's other features of it. So this is, I think, maybe most relevant to the election, but the biggest thing I think, and this gets back to the question that I posed at the beginning, why haven't we fixed this problem, is that there's inertia and a large sort of meta trap that we can fall into, right? So individuals fall into traps. Places can fall into traps. Policies can help people get out of those traps or not fall into it in the first place. But what shapes that structural environment? And that's the meta trap. And here's a sort of a depressing story, but this goes back to the great migration of Black individuals. This goes back to the great migration uh, in the 1940s and 70s, Black Americans leaving the South to try and find better work opportunities in the North. And the sad thing is that as more Black Americans, adults moved to the North, they were actually less likely to achieve opportunity. So they went to Philadelphia, New York, Minneapolis, Boston. It didn't work out for them, even though that was the explicit purpose. Worse, not only was there less opportunity or less upward mobility, migration out of the deep south actually reduced life expectancy by a lot, right? This is like half a COVID or something. So that's huge. And the question is why? And it turns out that northern cities, Philly, Boston, New York, um, Minneapolis reacted to migrants coming in through increased racial residential segregation, increased investment in police and incarceration. So things in ways that effectively preserved some of the kind of the racial hierarchy and power dynamics in favor of the people who were predominantly white who were living there already. And this plays out over and over, right? Um, Anytime there's conflict between groups, population groups, the dominant group exerts its power to sort of preserve that hierarchy. And why is that? A lot of it has to do with the way we think about things. There is this narrative which has only increased, I think, in the last 10 years, that some people doing well means other people do not. There's how we weigh trade-offs in general that I think um, belie certain beliefs about kind of the value of different programs. And then there's also our lives, right? Like we live in specific environments, we know our context, but we make inferences about the world from those contexts, and those inferences are usually wrong. So let me tell you a little bit about zero-sum thinking. This was from a paper that it's an experimental paper where some sociologists basically randomized people to the belief that upward mobility is possible. That's this gray line, and then other people were randomized to not believe that. And what they found was that higher SES people, when you were told there was more upward mobility through this experimental treatment, were less likely to support redistributive policies, right? So when there is more mobility, the people who have kind of achieved the end state of mobility or are holding on to a high social status feel like they have to lose, and as a result will not try to support policy that might increase mobility for everyone. So these are the breaks. You can also see this play out in history. So this is a study of ours. This was actually what I was going to do a whole talk about. But this is a study of ours where we looked at the extension of the Voting Rights Act in the 1970s. And the Voting Rights Act did a couple things. It increased the political power of non-white groups. It provided more public services to both white and non-white counties. And looking at measures of income, employment, labor force participation, no one was worse off as a result of the Voting Rights Act, and white individuals actually did better. To the point where if you look at infant mortality, for both white and non-white births, you actually saw infant mortality fall. But for adults, white adults, and this is the 50 plus group, their mortality actually increased. And this is a relative increase. So what it meant was that it's the decline in mortality slowed and halted in these places with the Voting Rights Act among white adults. And we've gone through lots of different explanations, but our belief is that this has to do with the racial threat, the idea that there was this relative increase in the power of a dominant group that created psychological distress and led to deaths predominantly from cardiovascular disease, even when infant deaths were falling for the same racial group. Um, just for the interest of questions, I'm going to skip this and just move to context-specific inferences. So, this is another reason why it's hard to kind of bring people around policies that deal with this kind of the traps we set and the transitions between them. Um, we all live in a world that we know, and we make inferences as a result of it. And systemic forces like segregation make it harder for us to know other worlds. So this was a really interesting simulation where they looked at people's beliefs about inequality. And the one is the standardized inequality, like they just set it to be one as a benchmark. If you're in a if your context is fully integrated, you will accurately believe that you accurately make a forecast about inequality. But if it's your neighborhood, your school, or your workplace, you are going to underestimate the degree of inequality in society. And that happens everywhere. And so it makes it hard to build consensus around policies if there's no agreement on the problem. How do you take on the meta traps? So what I'm trying to do with all of this and why I was excited to talk to you all in particular about it was I think the framing really matters. So there is a sentiment that we are not understanding about people, but I think it's in front of our faces as clinicians. And it's what we're seeing in the data, which is the aggregation of all the stories that we get the privilege of experiencing. And I think this common sentiment is something like getting stuck or trapped. I think it ends up tying the experiences of different groups together. So we worry about like disenfranchised white men. We worry about the legacy of structural racism. We worry about the long legacy of structural racism, structural sexism. We worry about what immigrants, the kind of the yo-yo that the DACA program, for example, has created among immigrants who qualified initially in 2012. All of this has to do with, I think, transient feelings of feeling trapped, feeling that there's opportunities, feeling stuck, feeling that there's possibilities. And what I'm trying to do is if people can agree on the sentiment, then perhaps they can see themselves in other groups. That is probably the most Pollyanna thing I've ever said. And as I heard it, as I said it, I heard that. But I really do believe it. The other thing that I think matters is that for meta traps is that anyone can get stuck, right? So and if anyone else gets stuck, it harms you. So I think I showed you that graph earlier where even in the highest educated counties, there's this flattening and slight increase in mortality. And you see it here. So this is counties ranked by poverty. This is the poorest county. This is the least poor. And this is Europe at the bottom. And this is us. This is white Americans. And what you can see is that the worst off, the best off counties in terms of white mortality and in terms of white socioeconomic status have higher mortality than some of the worst off European counties, right? And I think the fact that we set traps for a lot of people, don't allow them to flourish and contribute to society, is getting everyone stuck in this cycle. So the last thing I will say is, what do we do about healthcare, right? How can we lead by example? A really quick thing is that healthcare has gotten way too big. And the market activities, whether it's insurer consolidation, hospital consolidation, we're all at big medical centers, so I feel free saying this. Um, they tend to have harmful effects on the rest of society. So this is from a paper I just saw in the last week by an economics job market candidate. And what they show is that when insurers consolidate, and this is true for hospitals too, the prices of healthcare go up. They get passed on to employers. And then employers have to do something about it, either by cutting wages or not hiring as many people. So what happens is the employment to population ratio falls. Um, and this paper suggests that about a third of what we're seeing with the fall in employment to population among men might be explained by what's going on in healthcare. So we shouldn't do that, right? The other thing is we have this low wage workforce like Linda, where we have the opportunity, and I think we have healthy enough margins to do it, to actually invest in their care. Invest in their economic lives by paying them more. So Paula Chatterjee, Sasmira Mata, and I did a paper where it was in JAMA earlier this year, where we showed that Medicaid expansion, which improved finances in the states that passed it, led to on average increases in wages. But if you look at the distribution, it just increases the wage for people like me. But if you look at workers like Linda, they didn't see a dollar from it, right? So we could be better in sharing what is really growing sector finances across the board. We also do a lot of stuff. I mean, we, in theory, should be investing in the community more than we do. We also are very good as clinicians and as researchers at looking at evidence and deploying evidence-based treatments. So we should put evidence, we should figure out what those are at the community level and put our dollars behind them. But these are easy ways, I think, that they're not easy, but these are the ways that healthcare should lead if we want to think about the stuckness problem. I'm going to end with just a positive thing. Because I think we can get unstuck. And this is from someone who did it and had all the right tools to be able to do so. This is John. He had a long-standing opioid addiction, um, and he was my patient in residency, and I still keep in touch. And he told me he was clean for 6 months, and I asked him, I told him this is great, and he was on medication assisted therapy. Like, why'd you do it, or how did you do it? And he said, well, I just had to. I thought I had a future and I could make something of myself. And he elaborated that he had friends that cared about him. He was able, through a connection through a friend, find a job in construction, and he got a foothold in life. He was on the verge of buying a house. He had relationships that were meaningful to him. He felt excited and hopeful. And that has sustained him, I think, to today. John is doing great, continues to abstain. Anyway, I'll leave it there, but thank you so much for listening to this. I hope it is of use to you, and I'm really excited for your comments.
Thanks so much, Athene. That was really fantastic. If anyone has any questions, please pose them in the chat. I thought of a couple, and I think we'll have time for at least a few. I did want to say what I really love about your work is that I feel like when clinicians are researchers who come from a completely different discipline, it often feels like they're wearing like two different hats and juggling between two different roles. But what I really admire about your work is that your passion for just the well-being of people makes it seem like you're just wearing one hat, and you do have different roles, but you're kind of driven by this singular mission. So thank you for that really fantastic talk.
Well, I appreciate that. Thank you. Yeah.
One question I had, and I guess this is maybe more of a methods question, but it seems like every administration, every few years, we have such rapid shifts in policy and like ideology of the right policy. How do you account for kind of these rapid shifts when you're talking about such long-term impacts of social and economic policy?
Yeah, it's a tough question because you're right. Everyone's on sort of the electoral cycle. in the recent administration, one of the things they did, which I thought was very interesting, was they had the Office of Management and Budget look into cost effectiveness analysis, and they made two, I think, interesting changes. One was they decided that the OMB should score policies on the basis of all of the benefits. So if there's a labor market policy, or if something like Medicaid, whatever it is, take the total benefits from that policy, the socioeconomic, the health, et cetera, and then include them in a cost benefit calculation. The second thing is they recommended like a 10 to 30 year horizon to evaluate cost benefit. So if that's explicit in the way we construct our cost effectiveness assessments, I think that'll go part of the way. But part of it is that policies are partisan, and the fundamental kind of model of human behavior in the world that guides policies is very, very different. And so um, with the kind of political real alignment we've seen, there are certain types of policies, whether it's minimum wage, or I think paid sick leave is another one, where there might actually be wide consensus, and the possibility to have some durability with that. Um, the second thing I think that it comes to is just having a better narrative in talking about the policies. What's the goal of the policy? What are we trying to do? And then telling that to the people in ways that resonate with them or not. And so, to various degrees, administrations succeed or don't succeed with that. So that's my best answer. If you look at Medicaid expansion, like that, that has only kind of, no one has de-expanded, right? And slowly, most states now, over 40 states have expanded, and every year there seems to be a new one. And that's, I think, something that's a policy success, where people saw the benefit, they understand what it's for. Even red states have adopted it. It's been adopted on ballot initiatives. So the trajectory of that, I think, is something that might be replicated elsewhere.
Yeah, interesting. Thank you.
Mhm.
We are at time, but if I could ask you one more question about the Ignite trial, because I think it's
Yeah.
such a fascinating study. I'm curious about, given how localized the concentrated investment is, if you do find that these interventions are effective at improving health and well-being, who do you think are the stakeholders that become responsible for making those investments outside of a randomized clinical trial? Is it the city government? Is it the local
Yeah.
health system? Is it health insurers? Like who does the onus fall on?
Yeah, I think the onus would fall on the city and the, I mean, well, it just depends on your view of the world. Like, I think in the current world we have, it would have to be um, some conglomerate of the city, and kind of the health systems that are there, and potentially nonprofits. Like, that's just sort of how things have gone. And I think we've decided to put a lot of money in healthcare to solve social problems, which I don't agree with. But the way I see Ignite Trail is like we're sort of doing something that should have been done anyway, and we are correcting sort of either market failures or failures of governance. And so um, it's not a problem that the market will fix necessarily. And the way we have tried to fix it with markets by providing tax credits to distressed areas. So um, up by Drexel on Market Street, just north of you know, there's like an opportunity zone that, and it hasn't really developed, and where it has developed, it's the people that are benefiting are not the people who live there, right? And so yeah, so this seems like a government, it's like an infrastructure issue. It seems like a government issue to me, but people will disagree with that.
Thank you.
Hmm.
Well, we are at time, so thank you again for joining us, and for all of your amazing work that you're doing. And thanks for all
Yeah,
of our listeners for joining.
yeah, thanks for joining. I really appreciate it.
Have a good evening, everyone.
Take care.